aspiration, and energy to emulsify and remove the lens. When irrigation is initiated, the eye will reach an IOP equivalent to the bottle height. For example, a bottle height of 95 centimeters of water creates 70 millimeters of mercury pressure. Different bottle heights result in different IOP levels. When aspiration flow occurs, the fluid movement results in a loss of pressure in the eye. Surgeons see this as a shallowing of the chamber and perhaps movement of the posterior capsule moving forward. With gravity and pressurized fluidics, the higher the aspiration, pronounce the shallowing of the anterior chamber. Flow changes occur not only by a surgeon's command of the foot switch, but also by varying levels of occlusion of the phaco tip. The Centurion Vision System's active fluidics technology is able to detect flow rate, irrigation pressure, and vacuum, and compensates for the pressure loss by squeezing the BSS bag more to help maintain the surgeon-selected IOP. This results in a more stable anterior chamber. With gravity fluidics, since the fluid source via the bottle height is static, the pressure in the anterior chamber stability is dynamic. With active fluidics technology, since the fluid source is dynamic, the anterior chamber is much better able to maintain stability. Now, some surgeons use an air pump to achieve high irrigation.
Welcome, all of you, to be here in the hall at this point of time, but those who are not here, they don't know what they're going to miss. We're going to really have a truly and good knowledge and interaction, I hope, at the end of each topic, dealing with the lens removal technologies, the newer modalities of intraocular lens implantation, understanding the multifocality in our practice and adapting it, and finally the cutting edge that the femtosecond give us as an assistant for the phaco emulsification. So it's a real pleasure to invite Dr. Meena Kumari here to spend a few moments with us on dealing on how the lens removal has helped her in the recent times.
So good morning, everybody. So what is new in removing cataract and what is active fluidics? So I'd like to say a few words about what is active fluidics. You would have normally seen BSS hung in a pole from where the BSS is infused into the anterior chamber based on the gravity, the flow running from a higher gradient to a lower gradient. But in active fluidics, the BSS is placed at a much, much lower level and into a bag-based system. Hence the name active fluidics. And what are the components of active fluidics? It's intraoperative pressure, balanced energy system, IOP ramp, and irrigation factor. So the major components of active fluidics are intraoperative pressure and balanced energy system. And the emergence of active fluidics is for want of more and more technology to be applied to already existing safe technique. So how this intraoperative pressure works? So this intraoperative pressure is chosen by the surgeon and it is targeted by the surgeon and it remains the same all through the procedure. So this video, I'd like to draw your attention to the initial few seconds, which is a higher grade of cataract where active fluidics is applied. And here you'll see the moment, very rapid displacement of the lens iris diaphragm in high myope where the axial length is more than around 31 millimeters. Whereas when we use active fluidics with the lower intraoperative pressure, there is a very gradual infusion of fluid into the anterior chamber by which the lens iris diaphragm repulsion syndrome is almost not existing, and this need has been met with when we use this technology. And this is demonstrating lower intraoperative pressure in high myopes and also in a hard cataract. So apart from the technique of the multiple fragments and all that, how the technology works, there are the optical sensors which are placed in the irrigation pressure sensor system, and there is one which is called aspiration pressure sensor or vacuum pressure sensor, and they are linked with the optical laser sensors in the back bay system. So by transmitting impulses continuously within fraction of a second to the back bay system, the amount of fluid which is needed is pumped into the anterior chamber to maintain the intraoperative pressure, which is again selected by the surgeon and targeted by the surgeon. So did it not exist in other machines? In gravity-based machines where it is hung in the pole and passively the fluid infuses, you would watch that there is constant fluctuation in the intraoperative pressure, and I'll come back to this. There is a constant fluctuation in the intraoperative pressure at the time of pre-occlusion, partial occlusion, total occlusion, and also when there is a break in the vacuum seal. And whenever there is a fluctuation in the bottle head, there is a fluctuation in the intraoperative pressure also. And this tabulation shows when we choose a bottle height of 110 or 109, the intraoperative pressure is 80 millimeters of mercury as opposed to the normal intraocular pressure of 20 to 22 millimeters of mercury. And so this intraoperative pressure has to remain all through, and this is achieved in this particular machine, active fluidic Centurion vision system, to maintain the targeted intraoperative pressure. How does this technology work in special scenarios like complicated cataract? In complicated cataract, the technique is, it's a small pupil, so we have to expand the pupil after removing the pupillary membrane and using the pupillary expanders. And so I've been one of the initial users of Centurion vision system, and all my surgeries are performed on MICS platform. And this particular patient, I wanted to offer this technology because it's an already compromised eye. So I wanted this patient to get the best benefits. And the next day, the patient's expectation nowadays is my cataract surgery being performed as a refractive procedure. Whatever status I may walk into your office, I expect a clear cornea and round pupil and a quiet anterior chamber the very next day. So in this case too, the desire to give the best for the patient was there. And this I understood it's a very soft cataract and a sticky cataract. And there was a big thrust from the vitreous pushing the lens iris diaphragm and shallowing the chamber also. So I opted for 60 intraoperative pressure. The beauty of this technology in this Centurion vision system was that there is any spectrum of parameters one can use. We can opt for higher end of the spectrum like high vacuum and high AFR and higher intraoperative pressure. So and also we can opt for lower intraoperative pressure, lower vacuum and lower AFR. And we have a wide range to choose upon from. It's a wonderful technology complementing to our techniques. And perioperatively, again, this shows a very good cornea. And again, the intraoperative pressure targeted is achieved by a feature there, which is patient eye level. And also the tubings are made of, they are low compliance tubings, they are rigid tubings, and the bore size has been made smaller compared to the previous tubings. And in brown cataracts and small pupil, how does this work? And yes, this is very much complementary in brown cataracts and small pupils. Here I would like to focus upon another component of active fluidics, which is called the balanced tip with balanced energy system. Here the tip has got a sinuous curve as opposed to the Kellman mini flat tip, and this tip oscillates 192 microns in the distal end and only 30% of it in the proximal end, which is close to the incision. And in this small pupil, balanced energy system is being used. It took me some time to understand how it works, but after understanding this, this is a wonderful feature which has made higher grades of cataract complication free, almost complication free, and very pleasant day after the OR without any zonular dialysis or PCRs. And this is a mini flare Kellman tip, and this balance tip is placed in a sleeve which has got ridges. So the balance tip at the time of phacoemulsification, it doesn't get close to the incision, thereby transforming the thermal energy, inducing wound burn. I should disclose that after using the balanced energy system in all the higher grades of cataract, my wound burn has become almost 0%. And also, if you notice the CDE, the cumulative dissipated energy, which is a cumulative energy of both the torsional and also the longitudinal component, my experience is after using this, it has again come down, CD has come down by 50% of what it used to be, and the energy what I need to use in harder cataracts has come down by 25 to 40%. And that is all the more gratifying to the patients. And I'd like to share a small experience with different grades of hard cataract and active fluidics. And hard cataracts are almost 50% of your day-to-day volume practice in cataract surgery. And the hardness I categorize as stone hard, rock hard, or it is leathery hard or rubbery hard. So in these hard cataracts, the technique of creating a crater and multiple fragments to reduce the energy level, and also Dr. Abeser's technique of multi-level chopping, so that good, excellent central separation has been offered to the patient, and then eating the smaller fragments. I'd like to draw your attention here to a very important factor called the surge factor. This machine, apart from operating in a very lower intraoperative pressure, 40, I have standardized to 40, and I'm very comfortable with 40 intraoperative pressure. And in this intraoperative pressure and high vacuum of 500, 600 or 650, there is minimal or no surge in the anterior chamber, offering excellent safety parameter for managing harder cataracts. The very attractive feature which I was fascinated was the higher vacuum and the lower intraoperative pressure with minimal or no surge. And this demonstrates in these are 4 different surgeries demonstrating that energy level coming down by 60%, which otherwise I'd have used 100% in this case. And my longitudinal energy, which we call as intelligent phaco, I use it from time to time, and at the time of fragment removal. And using the balance tip, the holdability is also good. I had initial difficulty in holding the fragment, but once I step down on the power and increase my vacuum level, there is excellent holdability of each fragment. And the very next day, the gratifying results are very gratifying in harder cataracts. Patients are not willing to wait for a week or 15 days or so for their central SKs to clear and their fibrin membrane to vanish from the anterior chamber. And why should we go for lower intraoperative pressure when we are satisfied with the gravity-based fluidics with the 80 or 85 intraoperative pressure? Yeah, this is a patient with a glaucoma combined surgery with a heart cataract.
Wonderful exhibition of demonstration and teaching. It's amazing that this technology, you can do whatever scenario you have to deal with it, and this has a unique energy delivery system in terms of ozil and also that balance tip that you mentioned so well. That has changed how the lens material will be positioned at the bevel, at the tip, for in the next stage of its removal. So I think this technology has this unique components of energy fragmentation, the way it is the most desirable, and then this active fluidics you mentioned so well will take care of the stability of the chamber, and we saw all the videos, superb stability, but also it has such a unique anti-surge mechanisms inside that surge has become a history now. So thank you so very much for sharing your experience with this technology.
Thank you,
Thank
sir.
you so very
Thank
much.
you.
Any questions or any comments? I think what we have here for our consideration is what can we do to improve the patient's outcome in terms of his eye outcome, clear cornea, quieter eyes, minimal astigmatism, no negative effect, and that combining with his IOLs make them happy. So this technology, I think, gives us the first step or a platform to address our patient, which is at our heart all the time. So with that, I request this brilliant young man
Can I start, sir? So good afternoon, everybody. So you all just saw a wonderful exhibition of a very advanced phaco system being used to break down multiple hard cataracts with great ease from Dr. Meena Kumari. So when you have done such a beautiful cataract surgery, you have to combine it with an appropriate IOL to give the patient the very best. And when it comes to an intraocular lens, there are certain parameters which we really need to look into for an ideal intraocular lens. The slides are not moving. Yeah, thank you. So if you look at the Acrosoft lenses, I mean, most of you know the good qualities or the pillars which the Acrosoft IQ lens which has to offer. And they really can't be discounted. Most importantly being the biomaterial of the lens, which has a greater fibronectin binding capacity, which really helps it to have the stability and the adherence to the posterior capsule. And in fact, subsequent to that, the amount of inflammation induced is also quite less, and a greater adhesion, the lens epithelial cell migration is reduced, leading to reduced rates of PCO as well as capsular shrinkage. Then you have the biomechanics with the stable force haptics, which are engineered in such a way that they conform to the shape of the capsular bag, especially in high myopes where the lens has a greater tendency to rotate. These stable force haptics are extremely useful, especially even in the toric versions, to ensure that there is excellent rotational stability. Finally, the biooptics, which is ocular health and improved functional vision, wherein you have the excellent chromophore filters which are present within this Acrosoft lenses with a high refractive index, and also the aspheric design of the lens, which reduces the spherical aberration with improved visual quality. The Acrosoft IQ, as I earlier alluded to, which has the proprietary chromophore technology, which ensures that these, the harmful rays are not transmitted and filters both the UV and the high energy blue lights. Now, with this kind of IOL, which we were now, injecting it, rather loading it into our cartridges and manually doing it, which was working fine in our hands. So what is the need to be switching over to a preloaded IOL delivery system? Does it really improve our outcomes? Is it a question of just marketing the same IOL in a different design? No, I think it has a lot to offer. The preloaded IOL delivery system is really about making our safe cataract surgery even safer. wherein primarily we are looking at one consistent, predictable, and controlled insertion with the IOL injection. Now, with our pre-existing techniques using the cartridges with the wound-assisted platform, there was a significant amount of wound stretch which was being caused while forcing the IOL through a 2.2 millimeter wound. This can be greatly controlled with the newer preloaded IOL design. Additionally, the amount of handling of the intraocular lens while it is being loaded is greatly reduced. So therefore, there is a greater degree of sterilization which is available to us. Importantly, whether we load the lens or we have an OT assistant loading the lens for us, it is quite possible that there is a greater tendency for these haptics to get caught in the plunger. Occasionally, all of us have faced the situation of the haptic breaking, and it's quite irritating after that to be actually cutting the IOL, enlarging the incision, removing the IOL, and placing another IOL. All these can be completely done away with a preloaded IOL system. But very importantly, because of the reduced handling and reduced exposure of the IOL to the conjunctival sac, there is a greatly reduced risk of postoperative endophthalmitis, which has been proven in this study published in BJO, which shows a significantly reduced incidence of postoperative endophthalmitis when it was an injected IOL as opposed to the foldable IOL which was directly placed. When it comes to OR time as well, again, time is of the essence, and when you're doing a large number of cases, in this multicentric study across 3 sites, they showed that the OR time itself reduced from 6 to 12% while using a preloaded IOL delivery system. All in all, it definitely boosts efficiency, predictability, and safety of a well-done cataract surgery. So a little more in detail about the Acrosoft IQ platform with the UltraCert, where you have this UltraCert with this unique depth guard nozzle. And if you look at this nozzle, it very snugly fits, the outside portion of the nozzle fits into the mouth of your 2.2 millimeter wound. And it is only this small protrusion here which goes directly into the wound, ensuring that you can direct the IOL injection into the bag. You have a lens stop in this position, which ensures that it protects the IOL from getting displaced during transportation, as well as during your injection of the OVD. You have a plunger lock here, which again prevents the plunger from advancing forward during your IOL prep. And then you have the plunger itself, which has a unique tension glide. It's a spring-controlled mechanism and is exceedingly easy to use, and make sure you have an exceptionally smooth advancement and delivery, preventing any unnecessary jerks or sudden expulsion of the lens into the bag. So let me just, this is a simple video where you have the UltraCert system being shown in a little bit more greater detail. So it comes in a preloaded system, and subsequently you have the the nozzle here, the guard depth, the lens stop, the plunger lock, and the tension glide plunger itself. So what we have to do is that the company recommends that you inject an OVD, which is preferably viscoat, into this cavity, small cavity that you see here. And once the viscoelastic has advanced, then you remove the 2 locks and then advance the plunger. Now, advancing of this plunger has to be done gradually. They say you should take a period of about 7 seconds to ensure that the lens advances gradually towards the nozzle. And as you can see here, it's now ready for inspection, and both the haptics are well folded and the IOL is ready for lock. And you can see this elastic spring mechanism which you have here ensures that there is no sudden expulsion of the lens as it is being injected into the eye. So now again, concentrating on the depth guard nozzle, which you see here in this animated picture, it fits in very snugly into the 2.2 millimeter wound, truly making your IOL delivery even safer. So as alluded to earlier, this depth guard nozzle, in comparison with the other platforms, has shown that the wound stretch is greatly minimized with this technology. And as we all know, that the amount of wound stretch, the wound distortion, definitely contributes to our final outcomes, the surgically induced astigmatism, and this can be greatly controlled and reduced with the depth guard nozzle. Again, feedback from surgeons is probably what is most important, and spontaneously most surgeons have described this kind of tension glide plunger and the delivery system as smooth. And even with regards to delivery performance, they found that not even a single lens in this particular study had the trailing haptic which was caught to the plunger or any difficulty in ejecting it from the preloaded system. So I have a couple of videos here. One video where you can just see that the IOL being, this is the demonstration on the wet lab. So the first step is to inject the OVD into the system, and look at the way it is being held horizontally. I will show another video here where it's important that you hold this entire system horizontally and not vertically or perpendicular to you. You hold it parallel to your body and then inject the OVD. Remove the two stops. After you remove the plunger lock, then you start advancing the plunger towards it. And this is when, as I mentioned, take a period of 7 seconds as you gradually advance the plunger, and then the IOL is ready for inspection. And at this point of time, you can see if both the haptics are tucked in comfortably. So a quick couple of videos where I'm showing that this very snugly fits into this 2.2 millimeter wound where the phacoemulsification has been completed, and then the IOL can be very smoothly injected. You don't even require a second instrument, and then just directly is being tucked into the bag with the utmost ease and comfort. So one point which I wanted to demonstrate in this particular video is, now as you can see here, the mistake which I did, this was one of my earlier cases, where I'm not holding this parallel to my body, but it's rather perpendicular, so vertical in a sense. And as I inject the OVD, now this can occasionally lead to displacement of the leading haptic. And now I have not realized that while I'm injecting this OVD, but then when I remove the stops and then go on to the surgery proper, now here you can again see it fits in very snugly, very easily, very minimal wound stretch. But as you can see here, the plunger, the leading haptic is now already protruding out and not tucked in as it was in the earlier case. Really doesn't cause too much difficulty. You can still easily rotate it and place it in the bag with consummate ease. But then it's a small caveat to keep in mind that to hold the plunger tip horizontally. So to summarize, the preloaded IOL system definitely enhances the convenience and efficiency that you have in the OR, greatly reduces the risk to the damage to the IOL, which I think is invaluable to us. When you're doing a premium case with a premium IOL, you definitely don't want broken haptics for your case. Definitely decrease wound stretch, make sure that you're potentially minimizing the SIA, and an ideal delivery system for delivering the ideal IOL. Thank you so much for your kind
Thank you, Shreyas. I think this is very important. We already have a very good phaco machine which gives a exquisite control in lens removal, but it is the IOL delivery which actually stretches the wound, as Shreyas just taught us, and we never paid attention until we started realizing to improve our outcome better and better. And that's where the preloaded system and the concepts will really play a significant role in achieving the quality standard that we all want to give it to our patients. So thank you, Shreyas, very good. That kind of haptic coming out front, it's not a complication of a delivery system. That happens with manual system or anything. That would happen at times. So that's quite okay, yes. Can I run to the Alcon booth now? Right. I think it's a real pleasure to invite Ramesh Ramesh and Meena Kumari are doing a tremendous job and service in this part of the world, and they are brilliant surgeons, very well experienced. So he's going to talk and share with us how do we offer multifocal IOLs in our modern practice, Ramesh.
Thank you, sir. We were hearing seeing a good surgery and good unifocal lens implantation, and just coming to offering a multifocal lens implantation. Like we all have been good surgeons, good unifocal lens implantation procedures, but we never felt the need of the patient. So like when it comes to multifocal implantation, it is just understanding the need of the patient, elderly patients, what exactly the visual needs of their day-to-day requirements and the lifestyle, based on which the whole multifocal lens concept is developed now. Have we reached the summit of it? Not yet. We still have a lot of issues to be discussed upon. Like we are seeing an eye that is getting, the spherical operation keeps changing with age. So we need to address to so many issues when you come to multifocal lenses. What distance we really want to correct the patient to, distance, near, intermediate, all together, or is it only a distant and intermediate vision, which is the patient's real requirement. And we do have a lot of issues regarding the type of lens, technology, what we are using up. And as a early multifocal lens user, I've been used to technology of refractive lenses, wherein the whole two major difficulty will be is on addressing on contrast sensitivity and your photic phenomenon. And we all know that due to the dual focusing system, the light distribution results in contrast being reduced. And the various zones resulted in a lot of glare and halos. So we were giving the patient a more of distant and intermediate vision and more comfortable in the daytime, but not much of nighttime, lot of nighttime difficulties were inducing in the form of glare, halos and starbursts. But over a period of time, things are developing a lot. I need to spend a lot of pre-operative chat time to the patients, really make them talk to find out what is the real lifetime needs are, what is the type of personality of patients you are handling, and of course the ocular pathology is to be ruled out, and what is the vision goal, what are you aiming at, what is the, you are aiming at a more of a near dominant situation or an intermediate, what is the need. And of course on the measurement side we need to have a biometry. I'll certainly insist on an immersion, if not an optical, but certainly not a contact biometry. So it's more of an art than science. Like we keep talking to the patient, we develop our own skills. And as I said, we have evolved from a period of time when in 1983, when Hoffer did the first multifocal lens, he went through this concept by having a decentered lens, the dual focus, one through the aphakic and other through the phakic. Now we are come to the level of neuroadaptation, talking to the patient about various newer terminologies. And then came the diffractive lenses, and then after a period of time, slowly a combination of diffractive and with the refractive, which is what I'm going to really stress more upon, which is I'm more comfortable with. And basically it's a new lens design, which the basic lens design we are all aware of, the Acrysov single piece platform, hydrophobic. We are all aware of. Basically being a pediatric ophthalmologist, again myself, I prefer this Acrysov lens in my pediatric cataracts. And this, what is this apodization technology? Rather than having a different zones, which is adding up to the photic phenomenon, we are removing the foot. The central ridge is more larger. As it blends down to the periphery, it becomes thinner. So the light distribution is a bit uniform to avoid or minimize this contrast situation and this photic phenomenon. And this is the basis on which this lens works, which has got again an option of 2.5 AD, where if you are handling a patient who needs more of a distance and intermediate vision lifestyle, he can go for a low AD. He doesn't mind having a small near AD. And if you are looking at a patient who is more in need of more of a reading habit, then he can, without any compromise on his distant vision, because as the pupil dilates, the lens becomes a bit more of distant dominant, and the pupil is small, the central point is more of a near focus, so it is a beautiful lens for both near and distance together, with added together the minimization of the contrast decrease and the photic phenomenon. That is the beauty of this particular technology, which I have been of late regularly been using. And we always know that we avoid toric, anything beyond 0.75 as a choice we avoid. But then if we have a regular astigmatism, there is no higher order aberration like coma. If we have an aberration profile to measure, you can always still offer the patient a toric multifocal combination, if you are still confident about. Again, in 2.5 with a more intermediate distance combination. If we want to have an extended distance intermediate and near, we can go for a +3 again with the toric combination also. And even I tell my patients when I operate on them, there will be a possibility of a minimal requirement for a near add in certain dim illuminated situations. So these sort of minimal preoperative counseling is very essential so that the patient is understanding what's going to happen. And again, neuroadaptation again is one thing which we need to tell them about, that they don't get it immediately. So minimal halos and those things are going to vanish off over a period of time, which we have to counsel to the patients in advance. And as a pediatric ophthalmologist, again, when we operate on high hypermetropes, we may be handling a small esotropia squint component also. If they have amblyopia or a lazy eye, already the contrast is down, so they may be in for a surprise. So all such pre-op evaluation has to be performed improperly. So we all know that the ideal patient is who really spectacle independence, and it should be an easygoing personality, accepting to the minimal things that can once in a while go wrong. Maybe a small spherical error or a small spherical error, they don't really mind about it. And again, like whatever the task they require, if that is given, like where the reading is comfortable, they don't mind a little bit of a distance compromise. And the ideal initial choice of your patient's choice will be something like a moderate to high hypermetropia patient. They are because they are always dependent on their spectacles. And not so ideal patients, we all know the unrealistic expectations. If they are very nighttime drivers, to be specifically speaking, not to be avoided, and avoid low myopes because they are very excellent near vision in the presbyopic age group. And one other thing we can always, our scenario of patients in the culture, what our thing is, most of them don't have a proper eye evaluation before the age of 40, till presbyopia. Surprisingly, again as a pediatric ophthalmologist, we see a lot of anisometropias. Always do bilateral biometry. You may find that you'll have a lot of refractive surprises between both eyes in the astigmatism, K values, and even in the axial lens. Not regularly, but still once in a while. So always listen to the patient preoperatively. So what is the real patient's need, and based on which you plan your surgery, your lens, technology, anything. And again, astigmatism, I already dealt with, like irregular astigmatism to be totally avoided. If we have an aberrometer, avoid third order, higher order aberrations like coma and fourth order aberrations like keratoconus. And good macular function doesn't mean that we'll have to always have higher end gadgets. Simpler OPD evaluation tests like a pinhole test for distance and super pinhole test for a +3 add on an initial NS2, NS3 cataract. Anatomically looking at the macula, if possible doing a macular function test in the form of Amsler if possible. Any macular pathology like ARM, progressing diaberetinopathy, ARMD should be totally be avoided. Accurate biometry, again, nothing much to be insisted upon. IOL formula of your choice, whatever you are performing. And our protocol is we do all the basic evaluation, we do a biometry, we do a topography, we do a specular. Again, when you have a endothelial dystrophy or a corneal epithelial dystrophy, please do avoid them. Severe dry eye, avoid those cases. OCT macula, if you pick up some subtle retinal pathology, avoid them. And counseling, again, this is a major part. We do need to spend a lot of time. And then maybe once a patient chooses a multifocal, what we do in our center is we repeat the biometry on another day to get to an unviolated tear film. That is more important. So we need to have a spot-on biometry. And the basic minimum requirements to start a basic multifocal implantation in your practice, I'll say one designated calibrated keratometer which you handle by yourself, not anyone else, and at least an immersion biometry and a good macular function test. I think that can really kickstart a basic sort of, and a lot of scenarios I just thought of, I'll skip. And when it comes to surgical situations, we may land up with an intraoperative issues like a capsular tear, again debatable whether we can implant it or not. And again, on the mature cataract slide was I remember it's one of my classmate who came with the other eye multifocal, and we may have to be prepared. The next technology, I think we are going to see how we can handle these sort of complicated scenarios. Intraoperative issues, always be more clear on your prompt on your rexes, focus on your rexes, use new instruments. Many of us may have reusable instruments in your astigmatism induced by the wound, your rexes, overlap, everything is essential. Good PC polishing and visco wash from under the IOL. A good centration of the lens in the bag itself is a very effective thing. So as rightly said, it's always to under deliver and under promise and over deliver in a multifocal lens. Thank you.
Thank you, thank you. I think those who are using the restore or these multifocal options we have in this single piece platform based multifocal, I think we have this opportunity to understand the patient well and made for you or customize it depending upon the functional need or a requirement of that person, and can choose the traditional multifocal, which +3 is a good example, or newer designs like Symphony, like 2.5 or Oculentis 1.75. All of these lenses are low ads. Some companies will explain in a different manner, but in optical science and in real world, they all work as a low ad multifocals. And therefore, they will have an advantage in terms of the good distance and intermediate vision, but will have a problem with the reading. And all of these group of lenses would need extra reading glasses and increase the illumination in the office or in the room. But you can use both separately, or you can blend these two +3 or 2.5 in each eye, or +3 and Symphony, or whatever you want to do that, and satisfy the need or appropriate to the lifestyle of the patient. So I think we have this opportunity because of the single piece platform based various options of multifocality, different powers, with toricity, without, and so on. So I think here is the time for all of us to satisfy our more and more patients who are correctly desirous of depending less on the glasses. So just keep in mind when you go back home. Right, next one. Well, I think having understood the lens removal technology and getting a good control on the Centurion, can we do any better? Can we have some more assistance? And here is Dr. Sundaramurthy, who is going to share with us this femtosecond assisted cataract surgery.
Thank you, sir, Dr. Vasavada and friends. I'm going to be a few minutes for you to discuss about the technology, how you gain edge in your cataract practice. I'll take you through, so be attention for a few minutes, please. What we need at this moment for when you want to gain an edge in the cataract practice, you need to have a good technology and technique. Next, you need to know what are the benefits you are getting from this technology. Is that you're getting it? What are the things? I'm going to narrate to you one by one how we are going to get this, the advantage of this particular technology. So I have chosen LensX, the available best technology. In 2011, first it came to the market. And to remember, friends, this is the first technology to establish the laser refractive cataract surgery. Why? What is the advantage of this particular technology over that? Is the landmark identification, the anatomical landmark should be imaged for you to identify on the map. And the incisional architecture is another important parameter for you to do that. I find it's immensely useful, the reproducible capsulotomy. Whatever size you wanted, you get it every time. The customized lens, you know, you can customizable the lens, whatever you wanted to have. That particular technology is fragmentation. What is what? You wanted different methods of lens fragmentation, lens removal technique you can adopt. And you see that when you do capsulotomy, the machine brings to the capsulotomy to the pupillary center, positioning in the pupillary center. And the radial placement of the other incisions. Good docking, and any patient, you know, when you are doing on the topical, you have been on verbally coordinating with the patient and guiding the patient to focus on you. Look at this OCT technology. OCT takes you from the front part of the cornea to the posterior capsule, 8.5 millimeter, a single image. It's a great. And then it's actual real-time image. It's not a, already recorded. It's a real-time image guided planning. And you get a resolution, the contrast is very good. You can see that all the structures very clearly. You get the reproducible and precise the arcuates. Normally it's when the transepithelial around 80%, you get 9 millimeter diameter. Suppose you go intrastromal, you can even reduce the diameter. The arcuates are titratable. Either you can do on the table or you can do on the postoperative period, depending upon the amount of astigmatism you get on the postoperative 2 weeks. I just want you to look at this picture. How the overlapping and putting the lens into the back. This is also a manual procedure. It's putting the lens in the back, but you can, it's not uniformly covered. But this particular, even for the best surgeon, you don't get the overall uniform covering of the lens margin. So geometrically, it's better. Automatic centration and size of these lenses automatically takes place. The capsular HSR, though it's multiple spots, laser spot, it's comparable to the manual capsular axis. There are the different methods of lens removal. You can see the cylindrical method, and then you get a chop, and then you get a hybrid method and fragment. You can choose according to the type of lens you are handling that particular patient. You can choose the technology and then you go ahead doing it. I just show you a video. This video you can see my OCT picture and then the laser delivery. This is the incision. I think laser has been delivered already. You can see the incision. How easily it's open. You can just pass your instrument, the dissector. It just passes through. The femtosecond cut is in such a way that no resistance, no stretching of the wound, very easy to make it. The capsulotomy, I get around 75 to 80% of the capsulotomy is free-floating. And maybe some of the only, maybe 1 or 2% I have some tax to remove it. But even 90% of the patients, the capsulotomy is completely cut, 80% is free floating. And if it's well centered, so all the time you get the same size. And this, you can see that the capsule is very easily removed. Next, once you remove that, you know that you have a piece of cortex also. That cortex is, because it goes with the capsulotomy and you cut it, 325 microns, you go below the capsule. And then you can see the small hydro, small amounts of fluids is enough. Bring out the air bubbles to the front, and the technology is very safe in your hand. Then you go ahead to remove the nucleus. I just want you to observe this particular thing. You have segmentations. I have gone for a chopping of this segmentation. So I remove the superficial cortex. Then I just apply the spot suction force there, hold the fragment, just separate it. You can each fragment you can separate, and then easily you can take sections out. It is not producing any stress on the endothelium. It is not producing a trauma to the intraocular structure as much as you do in your manual chopping and technique. This is much more safer for your eye structures, and also especially the zonular system. It is not stressing the zonular system. So with this, then you inject, aspirate your the cortex and inject your lenses. What are the benefit I get it? What is the phaco time? If you do it in a system like this, is definitely the phaco time is reduced. There has been a study done by Cruz study. And then the pico power, 40% to 45%. If you're more experienced, then you can bring it down to up to 50% of your pico power. That's a great, safety to the intraocular structures. There is a less collateral damage to the cornea. The segmentation reduces the CDE into the eye, and less manipulation, because the fragments are easily coming. You don't need to manipulate. The less manipulation protects your endothelium. So day one study in the corneal thickness and also the volume stress all been greatly reduced. You get a predictable lens power because you know the ELP, where is the expected lens position. So you get a predictable lens power, expected refractive outcome. When the lens is there, your measurement is right, then your power, the outcome is very good. The manifest absolute error is very low. What you are aimed, what you got, the difference is very low. Stable position of the IOL, not decentering, producing refractive error. A stable position of the IOL get you the best correction. A well-positioned IOL, good centration is all our aim in a cataract surgeon. This is even more critical when you are doing multifocal or toric IOL. And the better IOL centration, all these things would be very easy for you. The other important thing, the deceptive influence of the axial length, the pupil, the K reading will not affect your femtosecond cataract. CCC is 28% non-covered and LRC is only 11% is not fully covered. The internal aberrations is maximum reduced by this procedure. And there is a posterior polar cataract done by Dr. Vasavada and team. And this is a surgical technique, femto delineation without hydrodissection. He has demonstrated, and this particular technology has reduced the PCR from 26 to 6%. So femtocorneal wound is customized, square shape, sealable, but tight wound closing, and you get assay is predictable how much you could induce the astigmatism. Castle-optim overlap is good. So I have two lens technologies at Lotus. One at Coimbatore from 2014 and the other one is in Kochi in 2017, October. Lotus Coimbatore completed around 780 procedures. 27% of astigmatism we identified. 1 second, sir. 10% of toric IOL. 17% we have done AK. And all premium IOLs have been performed. In Cochin, 92 cases in 4 months, and 24% astigmatism above 1.5, 10% toric IOL, and 14% AK, 30% international patient, all premium IOLs. So, to come to a conclusion, what I would say, LRCS with lenses, less damage to the cornea, more predictive refractive outcome, better IOL placement, better visual quality, effective PPC management, customized predictable wound closure, and less PCO. So thank you for listening.
Thank you. I think the key difference between what we have been doing and with this assistance of LensX and other similar machines is the predictability or consistency, as Dr. Ramamurthy suggested, Dr. Sundarmurthy said. We did a study where I did 100 consecutive Rexes and I could do in 99. My junior consultant could do it in 93 or 2, and my 1 year plus fellows could do in 82. So 100% of the time with this LensX, we can do it. And also the incisions. And that's because this technology, LensX in particular, has a unique capability of delivering the energy, and by variable aperture system that they have, and to my knowledge, this is the only machine which has, you can actually have a very precise delivery at not only the rexus plane, but also at the lens division and also for the incision. Therefore, all the three major objectives are done in a very predictable manner all the time. There is a debate it's accepted now that in a spatial situations or difficult, LensX and others have an advantage, but we still are not sure whether it is worth in routine cataract. I think what my experience is that it is even in a routine cataract that it really gives the surgeon tremendous confidence. And our junior consultants now are so confident because once they sit on the chair and they have a beautiful right correct size rexus and lens tracks created, their confidence level is different. So that translates into many other surgeries which are not without with only phaco. So I think even in a routine cataract, producing a controlled consistency is something which is we all want. The question is the money. I think it is that it is so expensive that majority of us are not able to afford it or sustain it. So that's the key, but otherwise this is a great technology, and I really, we do 40% of our cases with this technology of LensX. So I think we are now coming to the end. If you have any questions or comments, this is the time. But we ran through this technology, helping us, the surgeons, in terms of the energy dissipation, the controlled environment with these machines during implantation, using the right understanding of the multifocal lenses and these LensX. So I think we have many things now at our disposal to consider and adapt whatever one can under the realistic circumstances. So thank you so very much for your patient hearing. Thank you.
You can see it in her face and in her eyes, the appreciation and renewed sense of wonder now that her sight has been restored. Special moments that can be shared and cherished with her loved ones due to your skills and confidence. But how did we get here? As a surgeon, you know that the attention to detail at every step is what truly makes the difference. So when was that moment? Was it the moment the procedure was finished and sight was restored? Or was it before that, when the patient first looked into your caring eyes and knew that your skilled hands, along with amazing technology, would come together to make a successful outcome a reality? Each tool and device around you, precisely designed and selected to provide you increased precision and confidence during every step of the procedure. But even before that moment came, there was the realization that something needed to be done. The moment you knew you were equipped to help restore vision and exceed your patient's expectations. It's easy to miss the beauty and the precious moments that are oftentimes right before us every day. Proving skilled surgeons equipped with superior technology and support can truly make wonderful things happen. The Cataract Refractive Suite by Alcon. Helping surgeons help patients enjoy all of life's special moments.